So we'll just finish up here with this last concept of the disorders of motility, and that is that of intestinal obstruction and or paralytic ileus. So an intestinal obstruction is obviously any condition that prevents the flow of chyme through that intestinal lumen, or the failure of normal intestinal motility, even if there really isn't an actual obstruction, but just the failure of the normal movement of chyme through the intestine. And that kind of falls under two categories then if you think about that definition. So there's that of the functional obstruction and that of sort of the simple or mechanical obstruction. So the example of a paralytic ileus is a functional obstruction of the intestines. So this is the failure of intestinal motility, often occurring after abdominal surgery. So it's basically the failure or the lack of peristalsis. So there really isn't necessarily something blocking the way or something obstructing the flow of chyme. It's just that the peristalsis isn't moving, so the chyme just sits there, and it sort of, looks almost like an obstruction, but there really isn't anything blocking the flow of chyme other than just the lack of peristalsis. Again, very common after surgeries, specifically abdominal surgery, specifically abdominal surgery because the intestines just don't like to get handled and touched. And so when you go in for an abdominal surgery and you have to sort of move the intestines over or get them out of the way, they kind of shut down for a while and go into a little bit of a shock. So they don't necessarily like to get handled, and they kind of stop moving and the peristalsis stops working for a while. As opposed to like a simple obstruction where there's actually a mechanical blockage in the way, either a tumor or there's a twist in the bowel or something. And I'll show you a couple pictures in just a second on other images, so to speak, of intestinal obstructions. But a simple obstruction is an actual blockage. Clinical manifestations, initially it's a very crampy, sort of colicky abdominal pain that's oftentimes followed by vomiting, a really firm, distended abdomen. I mean, you touch their abdomen and it's like you're touching a board. It's just so hard and so firm and very painful, and they're very nauseous. And then there's really quite commonly no bowel sounds with some sort of obstruction because there just isn't anything moving. So why would there be bowel sounds? Diagnosis of a obstruction is usually based on clinical manifestations, so what this patient's complaining of, but also imaging, so an abdominal CT or something like that to sort of see is there an obstruction or what's going on. Treatment is usually quite commonly, and we do this all the time in the ER, nasogastric suctioning. So you put an NG tube down and you just sort of decompress and aspirate all of the gastric contents out. That immediately makes the person feel better. It immediately decreases their nausea and vomiting. And after a while, once you have a pretty large amount of volume that's now been suctioned and aspirated out of the gastric area, the distension obviously goes down as well. So their belly isn't near as firm and hard and distended after NG suctioning. They may need pain meds because of how intense the pain is during that distension. Anti-secretory agents could decrease the amount of gastric secretions and therefore decrease the amount of stuff in their stomach. If there is a complete obstruction, like let's say it's due to intestinal twisting or strangulation of a hernia through the peritoneal membrane, and it's sort of being pinched and cut off. The blood flow is essentially getting pinched and cut off through, here I'll show you. So here's an example of the intestine sort of falling out essentially through a hole of the peritoneal membrane, and sometimes this section right here can sort of get pinched and it occludes blood flow to this section of the bowel outside of the peritoneal cavity. That's a medical emergency. So oftentimes, depending on the degree of what's causing the obstruction, immediate surgical intervention is needed for those complete obstructions. And again, here is that image that I mentioned of the different types of intestinal obstructions. This is indeed a hernia coming out, bowel coming out through the peritoneal membrane. B is something called intussusception. It is basically sort of like a telescoping of the intestines in on itself, which definitely causes an obstruction and a narrowing of that lumen. C is a twisting of the bowel, or what they call a volvulus. And D is constriction adhesion. So let's say this person has had some type of bowel surgery. Um, and there's some adhesions and some fibrosis now that sort of almost like connect several of the bowel loops together that causes stricture and a narrowing of that lumen. So again, just some examples of simple obstructions, actual mechanical blockages in the intestine. Okay, so that is it for the disorders of motility. Now we're going to talk a little bit about peptic ulcer disease. So peptic ulcer disease basically develops because of mucosal protective factors that have been overcome by erosive factors. So it's a break or ulceration in that protective mucosal lining of the lower esophagus, the stomach, or the duodenum. Can be single or multiple, so there can be many ulcers in that mucosal lining or just one. It can be acute or chronic, and it can be superficial or deep. Superficial basically just consists of erosions that erode the mucosa, that's so that first inner layer, but don't penetrate to the deeper layers. As opposed to a deep ulcer is a true ulcer, and it extends through the muscularis mucosa and damages the structures below that. So damages blood vessels, damages the actual sort of perforates the GI wall, and can certainly cause bleeding, and even to take it one step further, cause hemorrhage or a GI bleed. So within this conversation of peptic ulcers, we're going to talk about duodenal and gastric, so stomach ulcers. And no matter which one you're talking about, no matter if it's duodenal or gastric, this just kind of shows you a cross-section of the differences between an ulcer that's sort of a superficial erosion ulcer, so it's just affecting this mucosal lining here, or an image of either a true ulcer that goes all the way down into the tunica muscularis layer, that goes all the way down into like the blood vessels and the GI wall and things like that. So obviously this is a bigger deal in terms of damage to the tissues themselves, but also risk for bleeding and hemorrhage and things like that. Okay, let's see. All right, so the first type of peptic ulcer that we're going to talk about is peptic ulcers that are found in the duodenum. So these are actually the most common of the peptic ulcers, most commonly found in the duodenum. There's a lot of different factors for the development of duodenal ulcers. Some of the major reasons would be an infection of the Helicobacter pylori bacteria that actually promote inflammation and ulceration of that mucosal layer. It could be due to hypersecretion of stomach acid and other hormones like pepsin. The use of NSAIDs is certainly a really big risk factor, specifically ibuprofen. And then acid production can actually be increased with the relationship of cigarette smoke. So people who smoke are certainly more at risk for peptic ulcer disease as well. Interestingly, for duodenal ulcers, they tend to develop in younger people. And the symptomatology of duodenal ulcers, the sort of classic presentation of a duodenal ulcer is that they have chronic on and off epigastric pain within 2 to 3 hours after eating. So basically what that tells you is that they have pain when the stomach has emptied. Because it's 2 to 3 hours after eating. And interestingly, again, very classic, very characteristic of a duodenal ulcer is that the pain is relieved very rapidly by ingestion of food. So it's this very classic pain, food, relief pattern. And we'll talk about why that is in just a second when we talk about gastric ulcers. So there certainly can be more than just pain associated with this duodenal ulcer. So the complications could be bleeding, depending if it goes all the way through the lining of the intestine or not. It could have a perforation. It can certainly cause obstruction of the duodenum or the outlet of the stomach as well. Diagnosis is usually made by endoscopy, so just putting a camera down and looking at the lining of the GI tract. Treatment is aimed at several things. So one, obviously relieving the causes or the effects of that hyperacidity in that particular area. suppressing that acid secretion, and then hopefully trying to prevent any further complications like a bleed or a perforation or things like that. And so this is a illustration of both sort of a illustration and then also an actual picture of a duodenal ulcer. So A is a deep ulceration extending through the entire mucosa and into some of those muscle layers. So this is where we're starting to get into the muscle and the blood vessels and all of that. And then C down here is actually a picture of sort of bilateral. This is the internal lumen of the duodenum via endoscopy. Bilateral duodenal ulcers, and this person has it due to chronic NSAID use. So just kind of a real image for you to sort of see this ulceration of this membrane. Okay, so that is duodenal ulcer. Now let's move forward and talk about gastric ulcers. So gastric ulcers usually develop in sort of the antral region of the stomach, just adjacent to those acid-secreting mucosa of the body of the stomach. Patho is very similar to that of duodenal ulcers. So again, the use of NSAIDs and an H. pylori infection certainly increase the patient's risk. The primary defect is an increased mucosal permeability to hydrogen ions, and gastric secretions tend to be normal or less than normal. So it's really not necessarily the gastric secretions, it's this issue of the breakdown of the mucosal lining because of these other pathophysiological reasons. Okay, so clinical manifestations, as you see here on the screen, very similar to duodenal ulcers in terms of the pain, risk for bleeding, that type of thing. But the pain pattern is very different between gastric ulcers and duodenal ulcers. So for gastric ulcers, the pain is immediately after eating, as opposed to the duodenal ulcer, which occurs within, after 2 to 3 hours after eating. And this basically is because, and so this is what I want you to truly understand and really get about the pathophysiology and the differences between the duodenal and the gastric ulcer, is that because the gastric acid production is increased as food enters the stomach, it immediately starts to irritate that stomach lining. And that's why with the gastric ulcer, you have pain immediately sort of when/after eating. It's very irritating. That gastric acid production is very irritating to the lining of the stomach. So then what's interesting then is if it's a duodenal ulcer, the duodenal ulcer would be relieved by a meal. Because as the pyloric sphincter closes to concentrate the stomach contents as food's coming into the stomach, therefore there's no acid and sort of partially digested food reaching the duodenum, because that sphincter closes between the stomach and the duodenum to sort of concentrate and do its work in the stomach. So that's why duodenal pain happens later. If there's a duodenal ulcer, the pain occurs later when the stomach is done doing its part and releases that digested food and acid into the duodenum. Now that's when a duodenal ulcer is going to start to have pain, because now it's coming into contact with the acid. I hope that makes sense. Treatment for gastric ulcer, again, similar, both the evaluation and the treatment of the gastric ulcer is going to be very similar to the duodenal ulcer. Oftentimes, treatment is usually longer. It takes a little bit longer sometimes for a gastric ulcer to heal versus a duodenal ulcer. The last kind of ulcer we're going to talk about is stress ulcer. So it's a peptic ulcer as well that's related to either severe illness, emotional stress, some type of neural injury, or systemic trauma. So it can be ischemic, usually within hours after some type of injury like trauma or burn, hemorrhage, something like that. Or I'm supposed to say Cushing ulcers. Ulcers that develop usually as a result of a head-brain injury that sort of messes up the neuroendocrine response. The biggest clinical manifestation that I want you to understand about a stress ulcer, they're at really, really big risk of bleeding. So really basically the evaluation and treatment of a stress ulcer is basically getting that acid under control, and usually that's done with suppression by meds. Okay, done with ulcers. Now we're going to move into talking about inflammatory bowel disease. So this is the definition of inflammatory bowel disease is chronic, relapsing, inflammatory bowel disorders that really have not necessarily a known origin. There's a lot of different factors that they think play into it, from genetics to immune reactions to, abnormal T cell responses. And the two inflammatory bowel diseases are, one, ulcerative colitis, and two, Crohn's disease. So there's a lot of similarities between these two inflammatory bowel diseases. They have a lot of similarities in terms of their symptomatology, but they also have some different symptoms as well, and they have differences in their micro and sort of macroscopic changes that occur within the mucosa in the bowel of these two types of disorders. So for example, the differences that I sort of mentioned are for an ulcerative colitis, the lesions in ulcerative colitis are only in the colon. So they don't impact any other part of the GI tract other than just very locally in the colon. And the ulcers are continuous. So it usually starts distally, like in the rectum or in the sigmoid colon, and it moves up proximally. The lesions then spread or sort of move up proximally into the colon, but it doesn't jump around, so it's very continuous. And once a lesion starts, the only way it gets from point A to point B is to sort of continue that lesion. As opposed to Crohn's disease, first of all, it can impact the entire GI tract, not just the colon, like ulcerative colitis. But it also can occur in patches, so it can be lesions here, there, everywhere that don't necessarily connect to each other, the way that the lesion is one continuous injury in ulcerative colitis. Okay, so let's take a step back here and really look specifically at each one of these types of inflammatory bowel diseases. So we'll start with ulcerative colitis. So it's a chronic inflammatory disease that causes ulceration of the colonic mucosa only. So again, it starts at the end, like at the rectum or the sigmoid, and may extend proximately up into the colon. And it can extend all the way through the entire colon, but only the colon. Again, suggested causes not completely understood, perhaps infectious, perhaps immunologic, perhaps genetic. There is some studies done with identical twins that really supports the genetic component of ulcerative colitis, because you'll see it happen in both sets of twins. So basically, the clinical manifestations that we see in patients with ulcerative colitis are all due to the mucosal destruction and inflammation of the mucosa. So you'll see large amounts of diarrhea, so 10 to 20 bouts of diarrhea a day. Usually the diarrhea in ulcerative colitis is due to the loss of absorptive surfaces, because you have that destruction of the mucosal surface, and also due to rapid colonic transit times. Bloody stools you can certainly see. Cramping, they have a sort of a very frequent and urgent urge to defecate. And it consists basically of these intermittent periods of remission and exacerbation, which also gives some light to think that perhaps there could be some type of sort of immunologic or autoimmune issue component to ulcerative colitis. Diagnosis is usually done by a colonoscopy and also looking at serum lab data. And treatment is basically, there's a lot of different things you can do sort of conservatively in terms of treatment for ulcerative colitis. So one thing that they might do during a very sort of acute exacerbation of the disease is to put this patient on bowel rest, so temporary NPO status, to rest that destructing and inflamed bowel. Sometimes they'll put patients on broad-spectrum antibiotics or steroids or immunosuppressives to try to decrease that inflammation. If they're not on bowel rest and being put on temporary NPO status, we would encourage these patients to have smaller, maybe more frequent, but smaller meals. Sometimes these patients, because of their loss of absorptive ability through their mucosal surfaces, they are at risk for sort of dehydration and electrolyte imbalances. So oftentimes these patients are hospitalized for IV fluid and IV steroid administration. So these are some of the more, there's a lot of medical management to this. There's some sort of lifestyle changes that patients can try, and these are more of the sort of conservative treatment. Now, the last resort treatment for ulcerative colitis is definitely surgical, and there's for instance, a colostomy to actually completely remove the colon is completely curative because the disease really only focuses and only targets the colon. So obviously if you remove the colon, then you've basically removed the disease. Now obviously that's very dramatic and probably isn't going to be the first choice of treatment, but certainly is a treatment and can be curative. Another thing to sort of really remember regarding ulcerative colitis is because of this mucosal and cellular destruction and inflammation and changes that these patients can be, especially if they've had it for this disease for a long period of time, they're at increased risk for colon cancer. Increased risk, more so than the general population. Okay, so that's ulcerative colitis. The other inflammatory bowel disease is Crohn's disease. Again, it's an inflammatory disorder, but this time it's different than ulcerative colitis in that it affects both the large and small intestine. So that's a big difference from the ulcerative colitis. Sometimes it can be difficult to differentiate from ulcerative colitis because there's similar risk factors and similar theories of causation. But again, the rectum is very seldom involved usually in Crohn's disease, where for ulcerative colitis, that's where it usually starts. So that can be part of the differentiating diagnosis for ulcerative colitis versus Crohn's disease is where the lesions sort of originate. And again, their lesions in Crohn's disease is different in that they're causes skip, quote unquote, skip lesions. So this is where lesions are kind of periodically found throughout the mucosal lining. It's not necessarily one continuous breakdown of mucosa the way it is for ulcerative colitis. The ulcerations can produce longitudinal and sort of transverse inflammatory fissures that can extend to the lymphatics surrounding the bowel. Anemia can certainly result because of, again, malabsorption issues, and this time specifically malabsorption issues of vitamin B12 and folic acid. And again, the evaluation and the treatment is very similar to ulcerative colitis. Okay. And then the last topic that I want to briefly talk about is irritable bowel syndrome. Irritable bowel syndrome is a functional gastrointestinal disorder. It doesn't necessarily have a specific structural or biochemical alteration like ulcerative colitis or like Crohn's disease. It's characterized usually by recurrent abdominal pain and discomfort, often associated with altered bowel habits that either present as diarrhea or constipation or sort of flipping back and forth between both. And again, any individual with irritable bowel syndrome can sort of experience everything on that continuum. It's not like they only have diarrhea or they only have constipation. They can have anything on that continuum at any time. Interestingly, this disease sometimes through research has been associated with other disorders as well, like anxiety, depression, and chronic fatigue syndrome. The patho is not completely understood, but there are certainly a lot of different mechanisms that are sort of proposed and sort of doing research on. There seems to be some type of visceral hypersensitivity. Oftentimes that hypersensitivity gets even worse, particularly with distension of the rectum. Abnormal intestinal motility and secretion, again, increasing or decreasing transit time respectively. If intestinal motility increases, then you're having diarrhea. If it decreases, then the person's experiencing constipation. It can be because of intestinal infection and overgrowth of some of the normal flora. It can actually, there's research being done looking at stemming from sort of a food allergy or intolerance. So the allergy can actually activate mucosal immune systems, which they think might have part of the problem. But again, it's not necessarily an inflammation, so it's not that there's necessarily breakdown of the tissue there was with an inflammatory bowel disease. This is more of just sort of irritability of the bowel to cause the increased or decreased motility and increased or decreased transit time. And then there can also be some psychosocial factors that play into irritable bowel syndrome as well. Those influences can certainly impact the brain-gut interactions and play a part sort of in those neuroendocrine reactions as well. Okay, so clinical manifestations of IBS. So lower abdominal pain, again, can be diarrhea predominant or constipation predominant or both. Again, you can see sort of this alternating back and forth between the two. Also, quite commonly presenting as gas and bloating and nausea. And what's interesting with irritable bowel syndrome is that these symptoms are usually relieved, or at least certainly get better, with defecation and don't necessarily interfere with sleep or things like that. Treatment is very much individualized. Sometimes, quite often, they'll use laxatives or fiber, depending on what the issue is, antidiarrheals. And diagnosis really is based on the signs and symptoms that the patient is presenting with, and also includes basically exclusion of other sort of structural biochemical reasons, like an ulcerative colitis or like a Crohn's disease. So that's just kind of an interesting little aside with irritable bowel syndrome in terms of basically having to rule out other reasons for some of these symptoms before they can rule in IBS. Okay, so I am going to now fast forward to the very end of the lecture. So again, remember in class today we started here. We started with slide 29 and we went all the way until we started to talk about the other accessory organ disorders. So we're going to just quickly pick up here. I know I'm jumping all over the place today, but I have a method to my madness. I'm trying to focus on what I think is the most difficult first. So we'll finish here now. Now that we've jumped around wonderfully, we're going to finally finish up with disorders of the gallbladder. So we know what the gallbladder does. We know that it sort of acts as the reservoir in the little sac, if you will, to hold bile until it's needed during digestion. And so we kind of have to talk about two different disorders of the gallbladder. One, cholecystitis, which is an obstruction or inflammation. It is the most common cause of gallbladder problems. So basically it's just inflammation of the gallbladder, versus cholelithiasis, which is actually gallstones, so gallstone formation. For gallstone formation, there are a couple different types. Often the most common type is cholesterol, but there's another type of gallstone formation that you can see with cirrhosis, which is called pigmented cholelithiasis. And there's a bunch of different risk factors for who or why someone might be at risk for gallstone formation. And you can see the risk factors here: obesity, middle age, female, Native American ancestry, and do they have other sort of accessory organ diseases going on. One way to sort of remember who's most at risk for cholelithiasis is to remember sort of a theory of the 3 F's. And that is that female, fertile, and female, fertile, and now I can't remember the 3rd F. Oh, fat. Oh, that wasn't very nice of me. Female, fertile, and fat. So obesity, females, and women that are sort of in that childbearing age is sort of how to remember sort of the theory behind who's most at risk for gallstones. Gallstones can obstruct or cause inflammation of the gallbladder, and it's actually the most, sort of common reason for gallbladder problems. Cholesterol stones form in bile that's supersaturated with cholesterol, so it sort of sediments out and causes actual stones to sort of form because of that adherence of that cholesterol to each other. There's several different theories there for why this actually occurs. But treatment, well, first of all, evaluation and sort of diagnosis is usually done by radiography, so an ultrasound to look at that bile duct and look at that gallbladder to see if there's any gallstones found. Sometimes, depending on how big they are, you let them pass. Or other times, if they're really large and they're obstructing the bile flow and causing jaundice and other types of issues, they actually will go in either surgically and oftentimes remove the gallbladder. So that's just kind of to sort of something to think about in terms of treatment for cholelithiasis or gallstones. And this picture is just amazing to me. This is a gallbladder that was removed because of these large gallstones. I mean, those are just huge, and a lot of them. So I can imagine that this person was probably having other issues as well. I mean, I'm sure there was, bile ducts being obstructed and all sorts of things. So this person might have presented with jaundice and some other sort of liver disease type symptomatology. But that picture is from the text, and I think that's just amazing. Okay, and then last but not least, disorders of the other accessory organ, the pancreas. So pancreatitis, inflammation of the pancreas, associated usually with several other clinical disorders because it's caused by an injury or some type of damage to the pancreatic cells and ducts, causing a leakage of pancreatic enzymes into the pancreatic tissue. Now, the problem with this pathophysiology is that the enzymes then cause autodigestion of the pancreatic tissue itself, and can leak into the bloodstream to cause injury to blood vessels and other organs and sort of wreak havoc in the GI system. Pancreatitis in terms of clinical manifestations and symptomatology, they're certainly going to have epigastric pain that sort of radiates to the back. You can certainly see fever and increased white blood cell count with pancreatitis. You very commonly will see hypotension and hypovolemia with pancreatitis, and it has to do with the fact that these enzymes increase the vascular permeability of the vessels in and around it. And you can certainly see an increase in the patient's amylase and lipase, which I talked about in my voiceover from Monday. Those are the big enzymes found in the pancreas. And when there's inflammation in the pancreas, there's an increase amount of amylase that's sort of dumped into the patient's bloodstream. And so an increase in either one of those, the amylase or the lipase, would certainly be an indication of pancreatitis. And there really isn't necessarily one particular reason why pancreatitis occurs. You can see chronic pancreatitis related to chronic alcohol abuse. So it's quite common to see sort of alcoholic cirrhosis and chronic pancreatitis go hand in hand. So, okay, I just wanted to briefly touch on pancreatitis. That's all I need you to know. I just wanted to make sure that you were familiar with that as well. So, I know we jumped around a little bit today. We started with liver and then went to sort of other GI issues and then ended with the other accessory organs. But I hope it was clear. I hope that some of the more complex liver disorders were certainly brought to light for you today during class. Thank you.